in this vaginal bleeding introduction lecture, what I want to do is give you an approach for how to handle vaginal bleeding by age group. This will be by no means an extensive list, but it gets you started in the path of creating an advanced organizer for how to handle vaginal bleeding. Then I want to talk about life-threatening hemorrhages from the uterus. So let's start off with that advanced organizer. Over the course of a woman's life, she'll go through menarche at 11 and menopause at 51. The pre-menarchal age group is pediatrics. The post-menopausal age group is older, and in between menarche and menopause is the reproductive age group. In each category, you want to have the thing that you're most worried about or need to consider, and also the most common. The most common cause of premenarchal vaginal bleeding is a foreign body, and this is usually placed there by the girl. In the reproductive age group, the most common is by far pregnancy. And postmenopausal, the most common cause is vaginal atrophy, especially after sex. Generally benign, and also the most common. The thing you have to worry about, the thing you should consider in the premenarchal age group is sexual abuse. Look for signs of vaginal trauma as well as STIs. In the postmenopausal age group, it's endometrial cancer. And in the reproductive age group, while cervical cancer is a consideration, especially postcoital, cervical cancer rates have been declining. So instead, this is where a lot of the differential is going to be considered. Pregnancy, anatomy, and dysfunctional uterine bleeding. The mnemonic is PAD. Dysfunctional bleeding is now referred to as abnormal uterine bleeding. And these are going to be the source of the things we're going to talk about as we move forward in these lectures. Some other stuff you want to consider in the premenarchal age group is going to be precocious puberty. And in the postmenopausal group will be hormone replacement therapy. Precocious puberty is going to be discussed in the puberty lecture. Endometrial cancer is discussed in the endometrial cancer lecture. Bleeding in the reproductive age female is going to be discussed in vaginal bleeding pregnancy. We're talking about early pregnancy here. Third trimester bleeding is handled in the obstetrics lecture. And then anatomy and dysfunctional uterine bleeding are going to be handled in vaginal bleeding anatomy. But you should also kind of know what you should do as a first step for each of these age groups. For the premenarchal girl, what you want to do is a speculum exam. But doing a speculum exam on a child may be traumatic, so consider doing the exam under anesthesia. For the reproductive age female, always begin with the UPT to rule out pregnancy. And the postmenopausal female, even though vaginal atrophy is the most common, you want to rule out cancer. That is, vaginal bleeding in the postmenopausal female is cancer until you've proved that it's not. And for that, you need some sort of endometrial sampling, usually in the way of a biopsy. This is my approach by age to vaginal bleeding. But then you also want to consider what happens when someone, regardless of the etiology, comes in who's bleeding a lot. Now, women bleed, and some women have more bleeding than others, and some women have meno or metro or both menometrorrhagia. Some women burn through pads or soak through tampons, and that type of bleeding can lead to iron deficiency anemia. In that case, all you want to do is give her some iron and find out what's going on and fix the underlying etiology. But if someone comes in with a life-threatening uterine hemorrhage, it's very similar to a GI bleed in the sense that it can bleed a lot, and there's no way to tamponade because it's just a hole open to the outside world. So you'll see a lot of parallels between GI bleed and severe life-threatening uterine bleeding. So if someone has life-threatening bleeding, you want to do the things that keep them alive. 2 large bore IVs. And you want large bore IVs in order to ensure transfusion of blood products. You're going to give intravenous fluid boluses to support the blood pressure while the blood gets ready. Type and cross, transfuse as needed. And then in the way of correlating with the GI bleed, this is the same thing, by the way, for a life-threatening GI bleed, you give IV protonics for peptic ulcer disease, empirically, hoping to stop the source of bleeding. In the case of a uterine bleed, you're going to use IV estrogen. IV estrogen is going to be the answer on your test and is a way to shut off acute bleeding of the uterus. And in correlation with doing the endoscopy and colonoscopy in GI, if the bleeding doesn't stop with IV estrogen, you're going to need to do some sort of surgical intervention. Very much unlike the GI bleed, where internal medicine needs to consult GI, the gynecologist or obstetrician is able to do this herself. So when you're considering, is this life-threatening or not, what you want to look at is a couple of things. The first is, of course, the hemoglobin. But the hemoglobin itself is not necessarily going to change. Because when you have an acute bleed, you lose both plasma volume and red blood cells. You may end up checking a hemoglobin and seeing that it's relatively normal or unchanged. So what matters is a severe change in hemoglobin over change in time, and you want to reassess after intravenous fluids. And you give them the fluid to reveal how bad the anemia actually is. A hemoglobin less than 7 is an absolute indication, but also you care about her symptoms. Right? The goal here is to ensure hemodynamic stability, and the way you can assess for that is by doing orthostatics. Frank hypotension is obvious. Hypotensive, she's in shock. But if you're orthostatic, you've lost a significant circulating volume, so you need to give that fluid back with crystalloids and get ready to give the blood. Regardless of what the hemoglobin may be, the velocity is heading down rapidly. And so you identify the person who's sick, you're doing the things you need to do, and then IV estrogen doesn't work. What can you do for surgical intervention? Well, surgical intervention can come in the form of an intracavitary tamponade. This is a temporizing measure where you simply insert a balloon and inflate it, and you hope the pressure against the endometrium prevents any further bleeding. Temporizing only. The preferred method is a DNC. The DNC usually can get at the source of the bleed, hopefully stop it, and preserve future fertility. If that doesn't work, or you're really worried about a vascular lesion, uterine artery embolization can be performed. Usually this is for vascular diseases like AVMs and fibroids. In this case, it's an interventional radiologist who does it. It can be done in the radiology suite without any surgery. But the definitive therapy for unrelenting life-threatening hemorrhage is a total abdominal hysterectomy. Of course, it removes the source of bleeding, so the bleeding stops. But also, removes her fertility. So in this lecture, we talked about life-threatening hemorrhage and the different options you have and how to manage them and how to make your decision as to whether if she's sick or not. IV estrogen is the answer on the test. And then we've had an approach to vaginal bleeding by age, talking about the most common and then the things we're going to discuss in the coming lectures. That's vaginal bleeding introduction.